In this video, we will discuss the CT-Fluoro workflow for robotic spine surgeries. This method uses a preoperative CT instead of an intraoperative one. An image intensifier registers the pre-op CT to the robotic software. This workflow is crucial for surgeons without access to intraoperative CT or when the scan and plan workflow is not feasible. The CT-Fluoro workflow uses preoperative CT scans for screw planning, followed by intraoperative fluoroscopy for vertebral registration and trajectory execution. Pre-op CT must meet specific requirements, otherwise the robot will not allow planning. The CT scan is imported into the robot console, where the region of interest is marked, and the software automatically segments the vertebrae. These segments are labeled based on known vertebral anatomy, typically using the sacrum as the reference. After segmentation, planning screws at individual levels can be challenging if 3D deformity distorts the vertebral segment. Restoring normal alignment by adjusting the axes is essential before proceeding with screw planning. In cases where the target pedicle is inadequately visualized, the software enables viewing of the adjacent upper and lower segments, simplifying the planning process. Next, we will see the planning process in CT workflows. This clip demonstrates the planning process for L4 and L5 segments. It is essential to ensure that critical anatomy, such as the medial, superior, and inferior borders, is clearly visualized in each segment where screws will be placed. During planning, axial and sagittal sections must be carefully analyzed to detect any pedicle wall violations. At L5, special attention is needed for the trefoil-shaped canal, which increases the risk of medial pedicle breach. Proper alignment of tulips in anteroposterior and lateral views is crucial to simplify rod placement. Which image intensifiers, or C-arms, are compatible with the CT-Fluoro workflow? Well, the robot is compatible with 9 or 12-inch image intensifier C-arms with BNC or Ethernet output. Currently, adapters for flat panels are not available in India. The C-arm adapter helps the robotic system determine cranial, caudal, and right-left directions. It is attached to the image intensifier, and as the video shows, it must be uniformly placed flush with the drum for detection by the system. The Ironman marker assists in C-arm setup by establishing the craniocaudal and right-left orientation. After verifying the C-arm tube orientation, no further software correction of the C-arm image is allowed. If the C-arm is accidentally rotated, the robot software permits reorientation. The video shows the process of registration and reorientation of the C-arm Ironman images. Like in the scan and plan workflow, the CT-Fluoro workflow requires the user to mark a head point and a foot point as shown in the video, followed by labeling an intermediate vertebra. If the drawn spine line is too short or too long, it must be redrawn. Next, the fiducial array is attached to the robotic arm via the extender, and the C-arm is brought in to take an AP shot, which is then captured into the robotic software. The image should cover the fiducial marker along with the region of interest. After acquiring the images and verifying adequacy in the system, the array and extender are removed and the robotic arm is moved to the oblique position. The oblique image is captured with the C-arm at a 65-degree lateral position. The array is adjusted to ensure clear visualization of both the array and the target vertebra. After capturing the 2D shots, the vertebra have to be verified with the preoperative CT. The robotic software offers automatic, semi-automatic, and manual methods for vertebral verification. In the automatic method, a single red dot marks the posterior-inferior border of the pedicle on the oblique image with an option to label the level. If labeled incorrectly, the system displays an error. If labeled correctly, it automatically detects adjacent levels and segments the vertebrae. The semi-automatic method involves drawing 3/4 of a rectangle on the oblique view to enclose the vertebra fully, with the line centered on the anteroposterior view. Correct labeling is crucial for successful registration. If other methods fail, manual segmentation can be attempted, but it is less reliable and may result in fluoroscopic images and preoperative CT mismatch. The next step is matching the CT and fluoro images, which the system rates as green, yellow, or red. Green and yellow levels can proceed, but red marked levels cannot be operated on. The final step involves placing 2 marks on the anteroposterior and oblique composite CT-Fluoro images and ensuring they align in both views. Cortical shadows of the spinous process or pedicle are typically used for reference. The screws are placed like in the scan and plan workflow. A special knife, guided by the robotic arm, is used to incise the skin and fascia. The sleeve, along with a dilator, is inserted through the robotic arm until the sleeve contacts the facet joint. A high-speed 3x30mm drill is used to create the pilot hole. This track is then tapped, and screws are inserted to the appropriate depth. Navigation aids in visualizing the depth during drilling, tapping, and screw insertion. Thank you for watching. If you found this video helpful, please like, share, and subscribe to our channel. Don't forget to check out our other educational content for more valuable insights. Stay tuned for upcoming videos.